that a face of a child tells many stories. And genetic and metabolic experts will tell us more about these patterns and stories and will give us an overview about what this approach should be towards dysmorphology. So, over to you, Dr. Mariam. Can you please take over?
Thank you very much, dear. I'm happy and glad I heard this is your first CME, our presentation. So I'm glad if it is the first one, so I can start it. And I will be
That's the
starting.
first Thursday. We have had several Salmania
Oh, okay,
experts
okay.
providing
So,
this. Nevertheless, it's a privilege for us to host you, Doctor. Welcome.
oh, thank you very much. As you have mentioned, dear, how much it is very fascinating to see from this morphology how we are able to reach to diagnosis of many complex and complicated cases. I always found this field of genetics very fascinating. The term dysmorphology was first coined by Dr. David Smith, an American in the 1960s. He's considered the father of dysmorphology, and actually all clinical genetists have his book, which is called The Recognizable Pattern of Human Malformations. We have always catch up with the latest edition released by it. It's called Smith, related to his name, David Smith. So what I would like to discuss first is a very important terminologies that we use. So when we say what is anomaly or malformation, we are here talking about a primary defect, a congenital anomalies that have started very early in the fetal life. It has occurred in the first few weeks of the fetal life and it had altered the structure. So this malformation can be a major one. And when we talk about major, we are talking about those who have a very severe impact that will be requiring either a very urgent intervention or has a very major impact in the child's life. For example, like omphalocele, meningomyelocele, cleft lip and palate, these will not be left without any interventions. So usually when we say about it, we are talking either about external that are seen, obviously, like the neural tubal defects, the anotia, microtia, the cleft lip and palate, or sometimes it is internally, okay, like the congenital heart defects, the tracheoesophageal fistula, the the intestinal atresia or stenosis, the renal agenesis. These are all internal malformations. When we talk about minor, yes, it is an alteration, but it usually, if it will have a minimal impact, and if it will intervene, it will be mainly for cosmetic reasons. For example, the picture where we see the finger to your left is what we call the little finger. We call it clinodactyly. Okay, or for example, I'm sure you've frequently seen with the right side picture where there is a ear skin tag or ear sinus. These are minor anomalies. Deformation is another terminology where there has been a fetal alteration, but it happened later in the fetal life. It should have been normal development of the organ, but because of something externally affected it and during the later fetal life. For example, again, very common is the talipes. Okay, very commonly you've seen it, and most of the time we relate it to its position. It should have been a normally formed foot, but due to external effect, maybe oligohydramnios or maybe a uterine fibroid, it has affected the position of the foot. Or what we see sometimes with the plagiocephaly, again, sometimes seen with uterine deformities where there is oblique. If you can see the shape of the head is mostly oblique. Disruption is again an external effect, an external compression or even a biochemical, but it is very severe, more severe than we have seen the deformation, that it will cause a more severe impact. a very common effect is what we call is the amniotic band syndrome. Very many times we get cases where they have absent finger, absent hand, absent arm, or sometimes even facial clefting. And we have to know it. Is it part of a syndrome? Is it a malformation? Or is it a disruption, which is most commonly seen with amniotic band syndrome? Dysplasia refers to abnormalities, mainly of histogenesis of formation of certain tissues, mainly affecting the skin, the brain, the bone, most common. So I'm sure you have heard of the most common dysplasias are these skeletal dysplasia, and this is already a huge topic. There is many books which are related to the various different types of skeletal dysplasia. And also other form of dysplasia, for example, the ectodermal dysplasia. Sometimes we see such cases where they come with very sparse hair. The dental, they will have either absent teeth, okay, or if they will have, as you see in the picture, cone-shaped teeth. Sometimes it can have affecting their nails. So many where there is the ectoderm, it will be affecting the, if there is genes which are relating, affecting the ectoderm, many we are relating it to ectodermal dysplasia. Now, what do we say syndrome? The most common every time when you mention syndrome to a family, the thing they will know most commonly is the Down syndrome. So, but what does syndrome mean? Syndrome means it is a well-characterized constellation of major and minor with a known cause for it. Okay, for example, again, the trisomy. So we know when we see the slanting palpebral fissure, when we see hypotonia, when we see the sandal gap, the single, the heart, we know when we, all this will give us a constellation of findings which we can relate to a certain disease. So sometimes syndromes can have mainly one or two features, or sometimes they can have more than that. But syndrome is different than a sequence or a sequelae. For a syndrome, it is 1 plus 2 plus 3. But for a sequelae or a sequence, it is 1 which led to 2, which led to 3. For example, the most common sequelae or sequence is the Potter, if anybody heard of it. So what started first in Potter is the renal agenesis. Now, why there is a renal agenesis, we don't know. Is it genetic or non-genetic? But the renal agenesis or any obstructive, for example, uropathy, have reduced to have the child to have reduced urine output, which we know is an important source for the amniotic fluid. So it will lead to severe oligohydramnios, and this eventually will lead to having very severely deformities involving the face. They will have squashed face. They even looked at like they're dysmorphic, how much it is squashed. They will have different joint dislocations. They will have different contractures. Because of it, there will be lung involvement. They will have severely pulmonary hypoplasia, which led to death. So Potter is a sequelae, something which led to Potter. So many times they will tell me this child is diagnosed with Potter, but Potter itself doesn't have a gene as Potter. We should know why there is a renal agenesis which led to Potter. The same thing is when we say the peri-Rubin sequence or sequelae. So the peri-Rubin itself is not a gene by itself. There's no thing. It is something which led to peri-Rubin. So what happens is actually why it is happening. For example, some newborns are born with severe micrognathia. Now, it cannot be fully understood, or sometimes it can be associated with syndrome, which is more commonly we talk about is the Stickler syndrome. So because of the severe micrognathia, there will be the upward positioning and the backward positioning of the tongue. And this would lead to affect the development of the palate, and eventually they will have a cleft palate. So it is something which led to the other. So this is the another example. How it is different from association. Association is different. It is again constellation of major and minor, but usually we don't have a cause for it till now. The most common association is the charge association, and as we know, the charge is synonym. See, for example, for coloboma, heart for heart defects. So each letter stands for something. So sometimes, for example, if you see a case with, let's say, corneal atresia, You should know, is it can be part of a charge association or not? Now, previously charge, we will not even do genetic testing for them. It was only a clinical diagnosis. But now, because we have many cases that were associated with CH7 gene, we started even testing them genetically. So there is a charge, there is the vectoral association, where majority have no clear genetic cause, but now so we do genetic testing for them because sometimes it can be associated with certain genes. So when you see a child, when you will suspect that there is a possible genetic etiology, again, if you see a child with anomalies, whether it is major or combination of major and minor, you have to search for the others. For example, if you have a case with, for example, polydactyly, an extra finger, are you sure it is isolated? There is no other anomalies with it? Okay, or some example for congenital heart disease, you should make sure it is only that there is no skull, there is no renal, there is no other associations, the patient doesn't look dysmorphic, because as we know, sometimes like congenital heart disease, we will not do genetic testing, especially for the isolated heart disease, because it is still multiple genes, it is a complex. But if we are suspecting syndromic causes, no, we will do for them. Growth deficit, whether they are short or they are tall, whether they are very obese or they are very thin. Okay, so this will let us to always think of genetic etiology we have to think about. Any developmental delay or developmental regression is even more suggestive of genetic disease. They will tell you this child was normal till this age, till, for example, 6 years. Then he started regressing. The girl was normal till the age. So the developmental regression is even more suggestive of some genetic etiology. And because genitalia, or if you see anything with multi-affected family members related to that phenotype. So how do we approach a dysmorphic child? I always, whenever case I see, I will always go back first to the pregnancy history. I'll ask the mother if she had any maternal illness, whether it was diabetic, she was having uncontrolled BP, she was having any certain medical diseases, was she on any medications, had she had exposure to teratogenous, how she felt that there was the fetal movement. You know, it is very important, especially those which are born with congenital hypotonia. Many times we will say, no, it was birth asphyxia, it was this. And then when we ask the mother, she will say that, no, actually, even the fetal movement, I didn't feel it was normal. Those who are always having postnatal growth retardation, we will tell the mother, what did they tell you about it? We will find that the mother said, actually, they induced me because of the not gaining weight, or no, they were always telling me that he was less than the expected for the gestational age. So always ask about this, ask about the ultrasound, even informations like polyhydramnios or oligohydramnios is very important. Birth history, especially those with developmental delay. Many times they will tell you, no, I'm sure that there was birth asphyxia, but nobody informed us, you know. So again, when we figure it out, they would say, no, he was discharged, he was crying, he was, so there is no clear history. So take more details of the birth history, family history. The first thing when they tell me genetic consultation, the first thing, did you take family history? Do you know there is consanguineous any? So family history is very important. Sometimes why I was mentioning about the diabetes, because don't underestimate the gestational diabetes, or especially if it is uncontrolled, because it can be one of the very strong teratogens. We have seen, I will not say very frequently, but we had cases with very severe anomalies which were related to it. Sometimes even we have cases where they have microtia, small ears. The first thing I will ask the mother whether she was having gestational diabetes or she was on medications, for example, acne medications, without knowing that during her pregnancy. طبعا we should think about if there was any history of infectious diseases, because sometimes they can be mimicking genetic disorders. There was a time in the 70s where they were using medication called thalidomide for motion sickness. And then they found out that many of the mothers that were taking it were developing patients with absence in the limbs, what we call ficomelia. So it was called thalidomide embryopathy era. Mothers that will have to be on anti-epileptic medications. Unfortunately, it can be teratogenic and they can have different anomalies, or areas where there is alcohol consumption and the mother takes it. They can have children born with fetal alcohol syndromes, and you will find them intellectually disabled. They will have dysmorphic features which are related to it. After taking the history, you will have to go to the physical examination. Always determine whether what the patient is having, is it a major, is it a minor, or is it a normal variant. So always we have to compare them with the family members. Always, whenever you can take possible measurements, it will always definitely be useful. So let's talk about some of the things. Sometimes you have newborns which are born both. Sometimes they can be born with severe IUGR, and these children need to be closely followed up even later on, because many of them will later we will discover that they have some genetic etiology background. Some of them will be having some, for example, Barter. We have many cases that will born IUGR, and upon following up them up, they were having always failure to thrive. And then when we did, we investigated them, طبعا lab, renal, and all this. So I mean, many of the IUGR cases, many have later on, we found that they had some genetic etiology which contributed for them being IUGR. Or sometimes the other way, they can be born for large for gestation age. Many times we have in the NICU, patients are born with having large for gestational age. They will be admitted for uncontrolled hypoglycemia. Always we will be attributing it for the mother having gestational diabetes. Then we will look more closely into the patient, as we see in the picture, which is to the left. We'll see, no, the patient has more coarse facial features. He has large tongue, macroglossia. He might be having umbilical hernia or sometimes even omphalocele. Then we start thinking about genetic, and we have sometimes cases that they present with this and they turn out to be the Pickwitt-Whitman syndrome. So large gestational age or IUGR both. Now about tall stature. This is also one of the frequent referrals that we get. And it was always one of the first questions that they will ask us to rule out whether he's Marfan or not. So tall stature is defined if the height is more than 2 standard deviation for the same sex and age. So Marfan, it's not only about the tall statures. You will have to look if there is other features which can be attributed to Marfan or other skeletal deformities. You have to expose him completely. You have to see if he's having any skeletal deformities. Is he having the facial, the malar hypoplasia? Notice, is he wearing glasses? Always have open the mouth, look to the habit of seeing the palate. Is it high arched palate? So it is always not about having, and we will talk about other signs sometimes that we can assess, help us. Take the arm span, take the height, and compare the arm span to the height. So this is when it comes to tall stature. Now, one of the very difficult also cases, and I'm sure we have the expert, Dr. Khadija, with us, because this is one of the cases which we are always being seen between us and the endocrinology more commonly. So short stature is defined now as the height is in the third percentile for the age or sex and population. Now, we have always to look as closely. Is he's having proportionate or disproportionate short stature? Okay, and disproportionate is more easier to tell us it is going to the genetic etiology, whereas the proportionate is, I find it very difficult. Is it constitutional? Is it growth hormone? So proportionate, we always have to consult our endocrinologist if they can help us with it, unless he looks very clearly syndromic. Otherwise, the disproportionate, which one is the short? Is it the trunk which is short, or is it the limbs which are short? And if it is is the limbs, which part of the limbs? Is it the proximal or is it the distal? Because each one will give you a different differential diagnosis. If a child, when he enters the clinic, you find that you suspect that he's having microcephaly, always take measurements, plot it on the growth chart, make sure how are the previous reading, so we know it is congenital or is it, relative microcephaly, and always compare with the other family members. And also the same way is it is very important for me, even with those which I feel no, it is the other way, especially those that they are referring them for us with the developmental delay. Even macrocephaly plays a very important, finding. So when we say macrocephaly, we should know what is exactly just causing the macrocephaly. Is it familial? Okay, is he was diagnosed with having, for example, non-obstructive hydrocephalus, or is it he's having other? You have to really look and dig what is the cause for it, okay? Or is it simply related, for example, nutritional rickets? So you have to look and investigate closely. Sometimes we had many cases, for example, with autism. So for me, autism is sometimes, with not all of them will do for genetic testing, because it is also, again, one of the complex disorders. But for me, for example, autism and microcephaly will guide me that it could be more of genetic etiology. So this is about it. And also you have to look into the newborn and even in the pediatric age group about the skull shape. Always look at from the head view. Do you feel that it is he's having normal head shape or he's having unusual? For example, is it oblique, what we call as plagiocephaly? Is he having flat occiput? Okay, if it is flat occiput, is it related to position? Because many times the first thing when you notice it, the mother will say, no, because he's always lying in this position. But is it true? Or is it you feel that there is something more to it, not just simply positional? Or if he's having elongated skull shape, which we call as the scapulocephaly or the dolichocephaly. So always look into the skull shape. But sometimes you will find very obvious abnormalities. For example, if you see here, if you see in this case, they're having the metopic suture early closure. So it will always having this like trigonal shape, which we call the trigonocephaly. And this glove shape is one of the very severe types of abnormalities. Sometimes you will have obvious abnormalities like an encephalocele. Encephalocele is sometimes we have, for example, just as I'm talking to you, they already consulted me, for example, for a case now in the NICU with this deformity. I have to examine the case and I have to make sure, is it isolated or is it having other deformities, or so we have to wait for the cardiac, the renal, other assessment. Is there consanguinity? Is there any family history? So this will give us a very important sign. Meningomyelocele, and I'm sure many of you and very have encountered cases with sacral dimple. Sacral dimple, we will not usually if it is isolated, unless again, it is always, why is it important we mention this? Because you have to collect. When you see one, you have to start collecting. Is there other things? Because as we mentioned, we have to combine and see them. That's everything isolated. Can it be, we will call it, okay, it is isolated. But when it is combined with other things, it makes you more and more suspicious. Even you cannot underestimate how much even looking into the hair will help us. Okay, the position of the hairline, is it anterior, is it posterior, is it abnormal shape of the hairline in front, like we can see here, like the arc in the front. The texture of the hair, if you feel it is abnormal color, abnormal texture. For example, one of the cases I encountered, they called me in an ICU. This baby was a newborn, and they called me because of they suspected he's having mild hypotonia. But what was striking more than that, when we opened the bassinet, it was full of hair. And the hair was a very abnormal texture and very sparse, and they were of Pakistani ethnicity. And we know that usually the Pakistani, they will have very soft hair, very more soft. When asked the parents, do you have like this in this family, they said no, this is first time we see it. And the parents were consanguineous. So with this, and we have to mention it because it is always important to mention these informations to get even the genetic result. And it turned out that he had a gene which was causing this, affecting the sulfur content of the hair. That was, he was having this type of hair, and it was also explaining why he was having hypotonia. So sometimes these things, as we mentioned, is very important. So many cases we came to their diagnosis just looking into the texture and the hair of the patient. I'm sure also one of the things you very encountered is when there is aplasia cutis. Usually if it is isolated, we just make sure was it an area where there was a probe and they pulled it, and it put a cause. But we do always a skull ultrasound to make sure there is no underlying deformities. We give them close follow-ups to make sure that the development was normal. Otherwise, if it is isolated, we usually don't do for them. Hairline, even the hair whorl, usually it's supposed to have single. Sometimes if it is double, again, we have to look into what other patient has other presentations. Many times we have the cases that they are referred for us for the white forelock. Okay, we have to do renal screening, we have to do hearing assessment, we have to look into the patient's face. Do we feel that his face is elongated? Is it round? Is it coarse? Again, the frontal bossing, and many cases, especially with this bitemporal narrowing, is a very important findings. It's sometimes, many times, it causes, suggests for us some neurogenetic diseases. Many cases, we look into the eye shape, we look into the eyebrows. For example, this case to the right, we have diagnosed many of them just looking into the shape of the eyebrows. If you can see, it is normal in the first 1/3, and then it is abnormal in the lateral. Okay, and in addition to that, not only that, you will notice that he has prominent ears, his abnormal eye shape. So all these will help us some in guiding us in diagnosing the cases. Years, many times they will call us patient is having low set years. We have to be very careful while assessing it. We always don't prefer the head to be totally in the flat position. We have to tilt up. We should make sure is it 1/3 of the line. When we draw a line from the outer canthi, at least 1/3 of the ear should be above this line. And these are some of the ear anomalies that we might come across. Anosia means totally absent ears. Microtia is small ears, and there is degrees of that, or it is protruding. And for example, protruding ears, again, it can be normal, it can be something familial. But again, when we add it to other things, it might mean something. Ear sinus, preauricular skin attack. Again, to the cause that we were talking about, the one with the macrosomia and large gestational age, we mentioned about Pickwood-Woodman syndrome. One of the things that we look into is also the ears, because they will have a ear crease. Sometimes it is seen in the anterior earlobe, or sometimes it is posteriorly. When we look into the eyes, we see the position of the eye. Is it the eye palpebral fissures are up slanting or down slanting? So we draw a line from the inner canthi to the outer canthi, and we'll see is it up slanting or is it downward slanting. So these both of them look the same, but why we sometimes call blepharophimosis and sometimes we say ptosis. Ptosis means it is mainly related to the vertical reduction in the eye, but blepharophimosis is mostly like microphthalmia. It is both the vertical and horizontal reduction in the eye. Hypotolerism is reduced in the interpupillary distance, which is different from the hypertolerism, where there is increase in the interpupillary distance. So again, apicanthal fold can be a very normal finding in the newborns, where you can see a skin tag. The skin is covering the inner canthi. Look, do you think that the patient is having a depressed nasal bridge? Look into the features, like, for example, the lips. Do you think that he has a smooth philtrum? Is he having a long philtrum? Have always a habit into looking into the teeth. Look into they has large incisor teeth, even cases with skeletal dysplasias. Look into the teeth, because multiple dental caries can also suggest that there is some underlying genetic etiology. Again, as we mentioned, the palate. Look, do you feel it is high arched palate? Rarely we can see some syndromics where they will have the bifid uvula. The neck, is it broad neck? Is it short neck? Is it webbed neck? Brachydactyly. What we mean by brachydactyly is they are short fingers, okay? Whereas arachnodactyly is the opposite. It is that they will have tall fingers, which mainly suggest marfanoid features. That's why when we are of the things which we do for one of the to rule out the marfan is we do the wrist sign and the thumb sign. When you close your hands on the thumb, hardly a part of it should be seen. But with the marfan, because they're having the arachnodactyly, a great part of the thumb will be seen. The wrist sign is when you try to overlap between your thumb and the little finger. Hardly you can touch each other, or if there will be slight overlap. Whereas again with the marfan, they can easily overlap each other. Camptodactyly is the outward curvature. Clinodactyly is the outward curvature. Syndactyly always habits look into the fingers, okay, because sometimes it will be clear, okay, sometimes no, it will be like webbing between the fingers, okay. And even for us, when we document this, it is even important to know between which fingers is the syndactyly. So we have to mention between the second and the third digit, between the, so even the which fingers are fused, or it is very important. Polydactyly is extra digit, so it is also important to know whether it is post or pre. Post, when we talk about it, as if it's the extra is to next to the little finger, whereas the pre-axial is next to the thumb. So, for example, one of the common things that you will come across is the post-axial polydactyly, especially when you do your post-natal examination. So when we see it, we'll always have to go back to the family and ask them, because sometimes it runs in families. For example, my son himself is having it. Why? Because his father was having it, because his grandfather was having it. So always, when you see it, go ask them, is it there in the family or not? Because it sometimes can run as dominant, okay? But we always do a renal ultrasound to rule out any renal associations. And always keep in mind also to ask about consanguinity. And if there is positive consanguinity, better to keep following them and closely, okay? Because sometimes it can be associated with certain syndromes where polydactyly is a part of it. Single palmar crease is a common finding and usually can be seen in normal, especially if it is unilateral, but very rarely seen as bilateral in both the hands. Look into the habit of seeing the fingers, because even dysplastic nails can suggest things. Absent nails can suggest, again, genetic etiology. At the abdomen, when we go to the abdomen, make sure you expose the child totally. Is he having white space nipples? If there are supernumerary nipples, sometimes they can be missed as, as birthmarks. Have a look into the chest. I'm sure you know the terminologies, the pectus excavatum or the pectus carnatum. Omphalocele and gastroschisis, again, usually if they're isolated, we don't do genetic testing, but when we see them, we make sure that it is not associated with other anomalies that may suggest genetic etiology. Especially the skin, looking into the skin can be very important to help you, as it can be a clear sign of some neuro involvement. So hypopigmentation and or hyperpigmentation, always make sure there is a proper neurological assessment, especially with cases with presenting with autistic behavior, presenting with seizures, presenting with developmental delay. They might suggest some genetic etiology. Lentigens are more darker, more smaller in nature, or any skin rash that you feel this following certain pattern. Sometimes we get the diseases, many cases, syndromes, where they will have special types of skin rash, which sometimes you see some areas are hypopigmented, some areas are hyperpigmented. Okay, so even if you see abnormal skin pigmentations, which is very different, and you cannot explain, especially in the context when we are talking about neurology, it can definitely means something. Sometimes there are certain diseases, they will manifest with skin findings, but they will come at different stages. I had a case which presented exactly with this type of deformities, and actually, because why he's having deformities, because he was having fractures that were started already in the fetal life. Okay, which is very commonly seen with OI, especially the severe forms of OI. Even the dislocations, okay, there might be hip dislocation, we commonly see in it. But if you see multiple joint dislocations, then again, you have to think about the genetic etiology. Also, whenever you have a habit of having any abnormalities, open the genitalia, make sure he's having ambiguous, is he having hypospadias, and don't underestimate even the undescended testes, because it means something when it is related, because some syndromes, they can present with hypogonadism. So sometimes one of the features that they will have is undescended testes. And this will be the end of my talk. If you have any questions, please.
Thank you, Dr. Mariam. That was very nice presentation and up for the topic. Any questions from the audience?
Yeah. Thank you so very much, Dr. Mariam. That was very comprehensive. I have a question now. What is the approach? Now, supposing we discover dysmorphology, like for instance, we had a child who presented with gastroenteritis, but we found that he had brachydactyly, single palmar crease, and short stature.
Yes.
He's 11 years old. So what is the approach towards the next steps? As in, do we go in for chromosomal, because all these tests are quite expensive. So how do we guide them? Do we get a karyotyping done? Do we get genetic testing done? Does one proceed over the other? Your thoughts on this. Thank you.
Yes, sure. Very good question. Because that's why we are always, prefer that genetic consultation is done for this reason. Because some of the syndromes, we are not saying that we are expert in all syndromes, because many syndromes, even we never heard of them. When we do the genetic testing, we only come to know about them. Because even the chromosome, okay, there is even other than the normal ones that we know. Sometimes they will tell you deletion in chromosome 13, deletion in this 15. Duplication in 21. So we cannot know all, but when we see them, sometimes we can see that this case is more of chromosomal or more of genetic. For the diseases which are, when you see them clearly, you know them, I'm sure you will request the correct testing for it. Okay, for example, this case, you're sure you think of it as Down syndrome. It's easy. You can ask for FISH, or if you want to do for karyotype. But for the other cases, it is not sometimes easy. Sometimes really you will have to go more than one testing to do. Okay, so it is sometimes they think that requesting genetic testing will solve all the cases. No, many times, and not only that, sometimes when you get genetic testing done, you will get sometimes unclear results. And then you will have to also correlate those results, and you will have to counsel these results. So always it is preferable, because many of these syndromes, sometimes we got more, our eyes are more tailored to see them, so we get more, it gets more for us, we get better with it. This is from the experience. But there is no such test as can be one used for all. Many times previously we used to go with chromosomal studies first, but it will be unnecessary wastage for it. So choosing the right test will always depend upon knowing exactly what could be the possible etiology behind it. Sometimes even you don't have to do genetic testing for them.
Yeah. Thank you, Dr. Mariam. And if we have to refer
Because,
a
for
child,
example, sometimes even they're complex diseases, we'll tell them no, we don't use for these things because it is multiple genetic, it is many factors contributing to it, not one.
hmm. Well, this child does not have Down's morphology on the faces, but on the face, he just has these spectrum of other dysmorphology.
Yeah.
Anyway, we've asked him to see a genetic consultant. So the next question is, what is the best way for us to refer a child from our facility to you in SMC?
Yes. طبعا
Is
yes.
yeah,
Sometimes some of the doctors they know me, so sometimes they send for us messages, and we try to collaborate with the clinic to arrange, for appointments. So those who know me, usually they send me messages, But otherwise, for those who know, usually they will have to go to the health center and get referred.
referral.
That's the way. Yes.
Yeah. So can we all, the people out here, doctors out here, can we get your reference so that we
Yes, sure.
can
You have the
collaborate with
big
you?
boss.
I'll take it. Yeah. Thank you. We'll take it from Dr. Khadija.
Yes.
Thank you, Doctor. Just a question. We used to have certain databases like, say, OMIM or such guidance to do some pattern recognition. So, what would you suggest? What is your go to database to organize some unknown
Yes.
diagnosis or fixing that? And how do you suggest online? Is it a part of your daily uh, routine to use some online database? How do
Yes.
you go about it?
See, OMM is still one of the best. Still it is, readily available, free. Before we used to have some databases like POSAM. It was an Australian, database. It was very excellent, but unfortunately, for the 1 year they have closed it forever. It was one of the spaces. Otherwise, we still go to OMM. It's still one of those available. They tried many cases, like there is phase 2 gene. There, but yeah, and still the OMAM is the only one which is available.
Thank you, doctor. Now, personalized medicine is becoming a concept. Uh,
Yes,
how often do you get references for
yeah.
genetic exploring of the
Now,
diagnostic
yes,
dilemmas and that kind,
yes,
like
but it was
ICU diagnostic
maybe.
dilemmas?
Yes, maybe I'm not sure if you are aware of something called a big project. They have started it. Actually, it's been
Correct.
now for 4 or 5
Even in
years.
Salmania, yeah.
Yeah,
So
it's in all over Bahrain. It is called the Bahrain Genome, project.
yes,
This
we happen
Bahrain
to
Genome
have some
project.
part of introduction in our organization also.
Yes,
Yeah,
yes, because I think, yeah, maybe they came for the newborn genome, because actually I'm also
correct.
A
Yeah.
member of the Bahrain genome. So what they are doing, طبعاً for newborn, it is a different, slightly different pathway, but otherwise for all the other population, part of the genome was testing the pharmacogenomics, okay, especially those drugs which are related to proton pump inhibitors, related to, for example, the warfarin, for example, those which are related to statins, and
Yeah.
so everybody is now knowing the importance of this, and they are much working and investing in it. But we do, apart from this, we do sometimes start getting cases, especially for those with uncontrolled hyper, cholesterolemia, hyperlipidemia. Okay, so we do get special requests for pharmacogenomics from the cardiology, whether it is related to the warfarin or whether it is related to the statins. It is still growing. Not everybody is aware of it. Not everybody knowing exactly, because even the interpretation of their results is different than the other genetic results. It is complicated results. So still it is a new field, at least in we would say in our population, but it is growing. We are going there. Even the doctors, they started being more aware about it from different specialties. But so far, most of our referrals are cardiology.
Okay. How about pediatric intensive cares, diagnostic dilemmas? They do not find out what's happening, and then one of the indications is to go for the genetic testing to
Oh, yeah, definitely.
conceptualize. How do you get that?
Daily, yeah, daily. It is a very growing field. We get daily consultations from the NICU and PICU. There is not even one day that I will not get consultations from them. For everything now they started thinking about the genetics. Sometimes it is even being abused. So that's why we don't even because you should know, you have to be very careful with the genetic testing and genetic results. It is not easy as it sounds, because many times you will get those results of uncertainty, and here you will be causing big dilemma. More than helping the patient, you might even keep unnecessary stress on their families, ask them to do unnecessary further testing. You might affect their future and everything. So sometimes I always tell the doctors, if you're sure there is genetic etiology, at least high suspicion of genetic etiology, it is good to do genetic testing. Otherwise, if you just do it without clear reason, you might end up with unnecessary results that you wouldn't know what to do with. So always we are, even so not all the consultations we get, we agree to do genetic testing for them. We choose, and we have to be very careful, because more dangerous than doing the test is counseling. Counseling is very dangerous. It has to be done by a specialized one.
So, what are the common things you have picked up in ICU genetic consults, like, and how expensive it is for any external ICU to approach you for whole exome, whole genome testing? Would it be an
very
option for us?
important.
And what is the cost?
You should also make sure about choosing the right lab. This is also, we gain it with our experience. Some labs, I get the result, I wouldn't look into the results. I will tell them, sorry, I don't look into this lab, because it is right, he will put me left, he will put me more in trouble. So choosing the right lab, choosing the right test that you need for it, okay, is very important. Most common we have is the neurogenetic diseases. This is the top we have. Okay, whether it is encephalopathies, whether it is myopathies, whether this one, neurogenetic is one of the most complex, because it is a complex disorder, and many genes are there. So it will not be easily for you to know the diagnosis without its help. Okay, you will say, okay, you're suspecting muscular dystrophy, for example. There is 100 types of now muscular dystrophy. How you will know? You cannot. You will give a main, just general terminologies. Okay, hypotonia. What type of what? Neurogenetics is one of the top complex disorders we are facing. Okay. Otherwise, the others, as I say, some of them, because it is very unclear, we do it, but we don't get clear results. When it is unclear case, it will be unclear results. It is always like this.
Thank you, doctor.
Yeah. So choosing again the right test, the right lab, okay, and giving the correct counseling.
Okay, so what would be the choice of lab for you?
There is different labs, I will not make advertisement for any,
I know, but
but
then this
yeah.
would be something we have
يعني
to choose. That's
yeah,
why.
yes, yeah. يعني there are certain labs we always prefer. Some labs we wouldn't.
Okay, so we would scale it up.
Because even some things I prefer it also again from certain labs. For certain things I prefer this. It's not a rule. I'm talking about
I
my
know
experience.
about
But each
the
one has,
authenticity
yeah,
that you trust. That is the thing that
yeah.
you're talking about. Okay.
Yeah,
Uh,
يعني, what I might like, someone else might not like. If I will talk, it's about my experience, my.
okay. So another question before we wind up:
Yeah.
how how difficult it is? How do you counsel a variant of unknown significance? You were telling it's dangerous, but how often have you encountered, and how do you
Oh,
counsel?
just now, before I enter this meeting, I had to counsel such cases. Daily, on daily basis. For example, if I will request 10, for example, 10 reports I will receive today. Okay. Uh, 7 might be of uncertain, 3 might be, or there are sometimes 50-50. Okay, so it is very, very challenging. It's very time consuming. You have to be very careful. We have to, again, sometimes we need to refer to other specialties to help us, because it is not that the genetic can solve all. So sometimes it is always discussion with the other specialties. Sometimes they need our help, sometimes we need their help.
Sometimes
And
they
it is,
also gain
as you
significance over
mentioned
a period of
earlier,
time. Yeah,
yeah, and as you mentioned earlier, it is at the end not cheap tests to be done. It is
exactly.
expensive.
Yeah.
So that's why I always tell them from the beginning, before deciding to do the genetic, we have to be careful. Only for those who really needs it should be done. Because if they don't need it, and again you get those of uncertainty significance, you will correlate with what? There is nothing much so you will be causing very unnecessary stress.
Yeah, but it is said such variants in future may be significant ones also. So
Yes, yes. That's why
so it
uncertain
is a difficult thing
significance.
when we make a
Yes,
choice to do it is because we do not have answers and we hope to give answers by genetic testing. So I do you have some red flags where you would really consider doing it, and I know it's a pattern, but then
hmm.
for the pediatricians who are listening to you, would you have some advices as to a list of such red flags where they will compose themselves to
Because
seek
what happens
genetic testing?
sometimes. Yeah, because sometimes we discuss with the primary consultants. For example, because we don't see, we see, as you know, different. For example, I will sit with their nephrologist. I want to think with him why he wants to take off genetic etiology. Sometimes he can convince me. Sometimes I can convince him. Okay. Sometimes we convince each that no need. So it is not I will do only the decision. I have to be with the primary physician, and certain cases, many times, we will tell no. Even if the primary doesn't think, we will tell him no. Needs, it is more of like this, like this, like this. So it is, first of all, different specialties will they have their different red flags. Okay, so I cannot say red flags about all specialties because each one has different red flags. And the endocrinology, they will have their own red flags. Nephro, their own. Okay, as we mentioned, sometimes it is between back and forth. Okay, endocrine. I'm just bringing endocrine because it is easier to correlate. They will think short stature is because of genetic. They will refer to us. We will ask them, no, but check for us the growth hormone, or we will do this or this. So each specialty, their red flags is different. There is no universal ones. It is always consanguinity is always red flagging. Okay, multiple affected family members is a red flagging for anything. Otherwise, there is no one which is used for all. Each one will have their separate. Each
Uh,
specialty has a different red flag.
Makes sense. And probably something life-threatening if you have encountered, and if you think
For
testing would
example,
make
I
a
will
difference.
just give you one example. There was a newborn. Okay, they referred the NICU to us. Okay, he stayed there. He was IUGR. I'm just giving a live example, which is recently we encountered. IUGR. Okay, he stayed with them and he had bleeding. I'm not sure, grade 1 or 2, something. Okay, which that time they didn't think it was needing genetic etiology. It is very commonly encountered. I'm sure if there's anybody from the NICU, they see it on daily basis. But then the NICU consultant, upon follow-up, they already discharged the patient. He felt that the patient development was not that appropriate for the age. Okay, although he was seen earlier in the NICU during the neonatal assessment neurology, but upon follow-up, the doctor wasn't very satisfied. He referred to us. So for us, yes, I wasn't happy with the tone of the patient, and what was red flagging for me was the consanguinity and their first child. So when we did for him, although the baby was alert, everything, he had very rare disease we call CD59. Okay, and we came to know the diagnosis. Imagine this child, after explaining for them and everything, he went into 3 weeks after he entered the hospital with severe encephalopathy. If we didn't have the diagnosis before that it was CD59, because CD59, they have special even treatment for them, we wouldn't know why he came with encephalopathy all of a sudden. You will start working up for viral, you will start working up for other things, and I don't know what, sepsis and all this. And till the time you get the genetic testing done, till you think of you get the genetic testing done, because it takes around 6 weeks, 2 months. But because we had it, it was very easier for us. He was ICU patient. He was very critically ill. So sometimes, it can be very life-threatening, the cases that comes. And sometimes it will take time. The problem with the genetic results is still takes time. Although there is something called as flash exome now, but it is very expensive still.
Thank you, Doctor. It's been an interesting discussion with you, and thank you. As we always say, it's an additional perk that we can
Sure.
discuss with
Yes,
you
I'm glad.
whenever we need and when we need a consult. Thank you very much.
Thank you, dear. Glad.
I think we will sign off. We extended our time, and thank you for your time, Doctor.